evening, everyone. Glad to see everyone. We are glad to have everyone at our January Provider Forum, where we're going to talk about StationMD, excuse me. So we have Dr. Trivedi is going to be presenting, and he is a board-certified emergency medicine physician, has been in practice over 20 years, and he has been an integral part of the core leadership of emergency medicine in provider groups throughout the region. He is a founding partner of StationMD and has been instrumental in helping the organization achieve its mission of improving the quality of care for the IDD population. So, and I think he is on. Let me see.
Yes. Hi.
There you are.
Can you hear me?
Yes, I
Oh,
can.
great. Yes. Thank you very much. I don't know. Do you have the presentation or do you need me to drive?
Either way, I can share my screen. Hang on one second.
That?
Yes.
Okay, great. Let me just go back. Great. Well, thank you very much. Really appreciate it. Thank you for having us. I think Kaylee from our team is on as well. And if you have any questions, like you said, please just put it in the chat. I'll try to be brief, maybe 10 minutes or so. But really, this first slide kind of says it all in terms of what we do. We are a organization with a mission of really improving the quality of health and therefore the quality of lives for individuals with IDD, intellectual and developmental disabilities. It's the only population that we serve, and we happen to use telehealth to deliver that care. I do really believe it is a game changer for this community in terms of supporting them. And by default, we also support provider agencies, DSPs, and the whole kind of disability ecosystem. As you mentioned, I am a physician by training, an ER physician, and I've been in practice for over 20 years. And we founded the organization 2017-ish with three other physicians and myself. Really, what it was born out of was my experience and our experience of seeing individuals with IDD coming to the ER for a variety of reasons. And number one, just seeing what they went through and their family members and DSPs, but also we really didn't understand how to care for them. Most physicians don't really understand this population. They don't understand the challenges that they have. Very little is taught to them about this community in medical school. And they really don't understand the challenges of provider agencies and group homes. And that's how we were really formed. We started with a group of about 40 individuals at a facility in New York City to where we are now. We are in about 22 states, covering over 40,000 individuals. I want to emphasize that all of our doctors go through a specialized training and curriculum to understand this population, understand their clinical needs. And just to give you a sense, last year we did about 45,000 virtual visits with people with IDD, and we've had well over 100,000 virtual encounters. So we really understand this population, understand their needs, and I think that's very important. Individuals with IDD deserve to have a specialized clinician care for them. And again, I'll talk a little bit more about that a little bit later in this presentation. We are members of many advocacy groups, keynote speakers. We speak at them. We take the advocacy part of this very seriously. We're members of the ARC. I spoke at the national convention. But I think it's important and incumbent upon us to really voice our concerns. The people that we care for really don't have a voice unless we speak up for them, and we take that very seriously. So, why do people with IDD tend to use the ER? And again, a lot of what I'm going to say is probably preaching to the choir. You guys know this, but outside of their underlying intellectual or developmental disability, they have other comorbidities, either pulmonary or GI or behavioral issues. And because of that, they tend to go to the ER for their concerns. Even if they have a primary care doc, it's not like that physician is available 24/7 or immediate, or maybe they don't have the same technology we do to visualize someone. And so there's an access issue. I don't think that's relegated just to Florida. It's or a rural area, urban. Getting access to quality medical care for people with IDD is very challenging. Unless you're really fortunate to live near like a specialty clinic or something like that, oftentimes the ER is your only, recourse. A lot of times individuals that are in your care with the provider agency, they're regulatory requirements. These are, I call them well-intentioned regulations with unintended consequences. Someone falls, you have to see a doctor. Someone takes the wrong med. You just want to, be careful and go see someone. Um, so because of that and a variety of other reasons, they use the ER frequently. And our goal is how can we treat individuals with IDD in the least disruptive, most stable environment, and that's their own home setting, of course. So, here's a picture of a real ER. It's a traumatic place. I call it the trauma of transport. Just getting someone there, you need specialized vehicle sometimes. You have to take a DSP off their shift. They have to sit with them for hours. It's frightening for anyone, but obviously for someone who's nonverbal or has sensory issues, you can imagine how challenging it is. I put in here missed medications. In my 20 plus years in the ER, I've had many individuals come just to get a med refill because they can't reach a doctor. And it seems like everyone runs out of their seizure meds on a Friday afternoon or something. And so, um, again, for many, many reasons, the ER is not the ideal place. And you'd be seeing me before starting this. ER docs, and I feel very comfortable saying it, they don't really have a special understanding with people with IDD. They don't know that constipation is a real issue or UTI, and oftentimes individuals get over tested when they're in the ER. I put in this. This is a screenshot of an article that came out in 2022. Um, Something like 84% of physicians did not feel comfortable caring for people with IDD. Um, for a lot of what I've already talked about. They don't get trained to care for them. And to be blunt, they're largely Medicaid, so that they feel the reimbursement isn't high. And, if this was another population, say, uh, physicians don't feel comfortable caring for poor people or people with pneumonia or people that are poor, this would be front page news. But, people with IDD, they don't feel comfortable caring for them. And one of our missions is to change that. So, you have this combination of poor care. Um, People get over tested. The typical scenario that I always tell people is individual comes with their DSP and the DSP doesn't really know them. They hand me a binder, like it looks like a phone book like thing, and no one reads it. I don't read it. I don't know where to find information. And I don't know if this person's baseline is. And so they get over tested. They stay there for hours. They decompensate. And of course, all of this is extremely expensive as well. So, if we switch gears to telehealth, and, you may have that yourself through your own health insurance or plan. I think if there's any silver lining to the pandemic, telehealth proved itself as a viable means of delivering care, not for everything, but for many things. And I would argue the value of telehealth for individuals with IDD is even greater because of what I've said. It's a challenge to get them somewhere. It's a challenge for them to meet someone who really understands their needs. Um, it is also a quality issue. We at StationMD can handle something in 20 minutes that would take 7 or 8 hours, transportation, a day or two to recover from. And I really do feel that it is something that can really improve the quality of life of the individual, also improve the efficiency of a provider agency, and save money. There are a lot of wonderful solutions out there, but the reality is if there is not a return on investment or a cost effective way to do it, these things don't have legs. And ours does because we are preventing ER visits, we're preventing hospitalizations. So on the left is a problem, the right is the solution. So lack of access to medical care. We can be in any part of the state of Florida as long as there's a cell signal or a Wi-Fi signal. There are no geographic impediments to us providing this care. The poor care that I feel this population receives, as I mentioned, all of our docs are trained to understand this population. We really understand people with IDD. We have access to their medical records as opposed to, the binder. When we see an individual, we know what their medical history is. We know what their meds are. We work with all of the EHRs that are out there, like Therap or Precision Care. We are on 24 hours a day, 7 days a week, and we provide full documentation of all of our visits. So after you see the clinician, we would send that note to the agency, to the individual, whoever's authorized to receive it, to the primary care doc. I will say, like, hey, Dr. Smith, I saw your patient on Wednesday evening and I thought they had bronchitis. I prescribe antibiotics. If you have any questions, please call me. And that documentation is also written in plain language so DSPs can carry it out, they can understand it. And of course, if they have any questions, they can contact us. I want to emphasize that not all cases need to be emergent. We do med refills. If you have a question, as I mentioned, constipation in our population, if it's not addressed, turns into bowel obstruction. UTI, if it's not addressed, turns into urosepsis. So we are there to answer questions. When we started, I didn't really appreciate the amount of support that we provide DSPs. They're amazing people that are coaches and chefs and chauffeurs, and they shouldn't have to be medical. They shouldn't have to be clinical. And so we kind of take that off the table, and they call us for a variety of medical issues and questions. This is just a screenshot of that portal that I talked about. We call it Station Connect. You would have access to this. Everything's in there. The person who called, the time of day, the doctor's note. Obviously, it's all HIPAA compliant. You can run reports off of it. All of that information will be accessible to your agency or whoever's authorized. Lastly, I just want to touch on some of the outcomes. And it's maybe a little dated, but 93%, meaning over 9 out of 10 times when we get a call, we are able to resolve the issue and keep the individual in their home setting, meaning we don't need to send them out. And some of the reasons we get called, again, this is an older slide deck, but they're about the same, are probably things that you're familiar with: cough, fall, COVID, vomiting, diarrhea, fever, cellulitis, UTI. The light blue are the ones that we keep, meaning we don't send them to an ER or urgent care, and the dark blue are the ones that we send out. And I will also add that whenever we send an individual to an ER or urgent care or anywhere, we call in advance. So I will say, hey, doctor to doctor, this is Dr. Trivedi. I'm sending John from this group home for his leg that's swollen. He just needs an ultrasound. Try not to make him wait in the waiting room forever. He doesn't need a CAT scan, doesn't need blood work. It really does expedite the care. The physicians really appreciate it. It's, like I said, the gold standard for them because they don't have to sift through a book or try to find out why someone's there. And it really does expedite the care, reduce the time that they're there. And also, again, I think it's a better quality of care. We did actually work with an organization called AbleLink to survey individuals, and they were overwhelmingly happy with it. I mean, we wanted to ask individuals themselves, and the survey was for people with intellectual disabilities that are nonverbal or have other issues, and they loved it. And again, it's a no-brainer. Like, do you want to sit in the ER for 8 hours, or do you want to stay at home and do what you love and get it over within 20 minutes? These are just some cost saving slides. This is an agency we work with, Pennsylvania. After paying for our services, still felt they saved about $82,000 annually, because they're not, paying for transport, overtime costs. And again, I can share this slide deck with you. This was an agency in New York that also felt that they saved a lot of money because of the impact that we've had. And I think, yeah, this is just a QR code. You can also go to our website. It's a video about how it works, but really simply, if you could connect on this call, you could use StationMD. It's actually a Zoom-based app. You don't need any equipment or anything, as long as you have an iPhone or an Android that can go on Zoom. The way it works is something would transpire. You call a toll-free number, and then we have someone on the other end who gets some basic information. And then you click a button, which connects to the doctor. And it looks like this. We can add a family member, we can add a nurse. I do my virtual visit. After the visit's over, I would send my notes to whoever's authorized again to receive it. We can do prescriptions. It's extremely easy to use. I do honestly believe that, again, whether you work with us or another telehealth organization, in this day and age, there's no reason that an individual should be going to the ER or urgent care for a simple issue like a cough or a fever or a med refill. It is, I don't look at this as a substitute. I look at this as superior care because you're seeing clinicians who really understand this population as opposed to, the ER where you're just seeing a random ER doc. So, um, I will stop sharing. I apologize for my voice. I've had bad cold, but please let me know if you have any questions, and let me see if I can stop there. There you go.
Great. So I'm going to go ahead and open it up for questions. We don't
Sure,
have anything in the chat right now,
sure,
so people are able to unmute themselves and ask. I know we have some providers on.
sure.
Don't be shy.
We
We'll
do
also,
we do actually work in Florida. One of the good thing is we are licensed in Florida. We're credentialed. So one of the issues is that we get is that, how long would it take to get started? And it would be immediately. I see someone ask for the cost. The cost is, and Kaylee is on, she may know, I should know this, but I believe it's $40 per person per month, and that's for 24/7 coverage for everyone. We don't bill the individual anything. There's no copay. We try to get reimbursement from Medicaid when we can, but that doesn't often work. They don't pay that well, but that's the cost for the whole services per individual, $40.
so I'm going to
Yeah.
call out Jennifer Radigan at the ARC Tampa Bay because I know you guys use StationMD. Can you kind of talk about what you like, maybe what you don't like, how it works for you?
Yeah, so I know I connected Kaylee with you because we've used the service for a little over a year now. And I think the biggest thing, and this was touched on, was avoiding urgent care or hospital visits for individuals that have struggles tolerating that. Another big thing is I know like anytime any individual falls, we always have somebody contact a licensed medical professional. So when that's around the clock 24/7, that makes it easy when it's in the middle of the night, especially if it involves a head injury where more than likely you probably would typically go to the ER. But another huge benefit of it has been related to the medications. So unfortunately, although we should know ahead of time that somebody's about to run out of a medication, it's a 5 o'clock med pass. And sure enough, the med's not there. Physician's office is closed. We all do not want med errors, nor do we not want the individual to receive their medication. So it's helped significantly with just having the ability to maybe get a 1 or 2 or 3 day fill of something super important during the meantime that we are reaching out to their regularly regular physicians related to whatever that medication might be. So it's been huge for us. It's well worth the investment that we've seen. Again, talking about your overtime comment, sending a staff that you have to bring in to sit in an ER for 7, 8 hours, paying time and a half, that's a significant cost. So it's been huge, and we couldn't be any happier with the service.
Thank you. Thank you so much. Yeah, I mean, Jennifer, one of the things that you mentioned really is critical is that um y- physicians that you may have, they're not necessarily available immediately, and oftentimes, you need a med, but the whole issue of falls, we get that a lot. And you know, everyone knows 99 times out of 100, everyone knows a person's fine, but God forbid you're wrong. The first thing they're going to ask you is, was the individual evaluated? Did they see a clinician? Did they see a doctor? And now you can easily do that as opposed to, okay, I got to take them to the ER, urgent care, just to like make sure that someone, tick that box. And we do that often. So that is something. And then the med refill, like I said, that's just not your agency. That's around the nation. People run out of meds. It happens. And there's no reason that someone should have to go track down a doctor or go to an ER to get a med refill. So I appreciate the comments. Thank you.
We've had a couple questions in the chat regarding cost,
Yes.
and I wonder if you could just go over that again. So you said you do try to get reimbursed from Medicare, is that correct?
Yeah, so we have a per member per month charge that we charge. And again, I think it's $40, but I can confirm that. And then if it's a medically relevant visit that we can actually bill Medicaid for or Medicare, we will. But we don't always do that. We don't always get reimbursed. We never ask for a copay. And a lot of the visits that we get, we can't necessarily bill. Like if someone calls and like COVID's a great example. We had a lot of questions around COVID, rightfully so. And we're happy to take those, but those are not billable, visits. Now, if someone has one, we will, but essentially the cost is that $40 and that's it. There's no other cost to the agency. There's no other cost to the individual, and to the provider.
Great, thanks.
Sure.
I'm looking through. What about question on specific pharmacy? Or would the meds be called into the individual pharmacy?
Anyone, any pharmacy that you use, we can use yours. We can use, the CVS down the road. We e-prescribe, so we work with all of them. We have contracts with the big pharmacy groups like Tarrytown or Guardian, et cetera, et cetera. But we also work with whatever pharmacy the agency is working with or the individual pharmacy. And then I see someone asked about who pays the 40. It's the agency that we work with is who pays that. If there's, I think Kaylee has put it in the chat.
Kaylee's quick. She's getting all the
She
answers.
is really quick. Yeah. I think she's with her kids, so that's why she's not able to comment. But yeah, it's with the agency.
So let's see. I'm going back up. How many providers are you using in Florida at this point? Do you know, or maybe Kaylee knows?
Kaylee might know. I know a few for sure. We are actually going to be working with a health plan called Florida Community Care, I believe it's called.
Yes, I'm well familiar with them. Yes.
Yeah, and a few other agencies in Florida, but I don't know the exact number. We had actually been to it's called FLARF, the Florida Residential Facility Group in
Yes,
Clearwater.
Florida ARF. Yes.
Florida ARF, yeah. And we had some interest from some groups there, but I don't know the exact number. But we can get that to you.
Okay. Well, no, that's just someone asked, but it does
Sure.
sound initially like a very good program. And I know the ARC Tampa Bay was pleased. And I think we have one or two other chapters that use it as well. So
Yeah, we work closely with, Anchor and NASDs. I mean, we're happy to provide testimonials, but again, I do think the benefit for agencies is really, having that medical support, staying out of the ER. It really is something that I think, we can get you some testimonials, but agencies have really seen the impact on their staff, on the individuals. And this is not a Florida issue. It's a national issue. Going to the ER it's a hassle. It's a pain. And so we can do that.
So it is based on per individual, not per group home or building. So if you
Correct.
have 6 people in a group home and only 4 want to use it, but it would be the provider's choice to who uses it.
Yeah, it would be. And our issue is more, we have no issue with doing that. It's just, you just never know when someone's going to need it. So we encourage you to, like, if it's a group of 3 in a home, like, cover all 3, but we're happy
Right.
for whoever you want. It just gets confusing because it's like, okay, who has access to it and who doesn't?
No.
If you have
Totally.
questions about that, you can just contact us. We don't have an issue covering specific. And yeah, as Kaylee said, there's no minimum or maximum with that.
And then Jennifer also mentioned that you can order labs and imaging that can come to the home.
Yes, yeah. Oftentimes, we'll order a UA or an X-ray. That's the thing. If someone falls and hurts their wrist or leg or whatever, they don't need to go to the ER right away. We can schedule, you know, the X-ray, or if someone needs a urinalysis, we can schedule that, or a blood test. And we follow up on all of those. We will work with you to get the results, act on those results. But yes, we order labs all the time.
What about, is it just for individuals in a residential placement?
No, anywhere in their own home,
Okay,
residential, day hab, yeah, all settings.
okay,
And then yes, it is 24/7. Correct.
great. Okay, I think at this point we have touched on everything.
Okay.
I'm looking through all the questions, so if there's anything else, let someone put it in the chat or just unmute and ask.
I'm gonna put in my email just in case if anyone has specific questions. And then again, we
Okay.
have a website. It's stationmd.com. It's pretty straightforward. And there's
I'm gonna go ahead and we usually do send the copy of the presentation out after.
sure.
So we'll be glad to send that, and we'll send the email addresses as well so that they can contact you.
Yeah, wonderful, wonderful. And again, if you have any other specific questions, you can reach out to me or Kaylee. And just really sincerely appreciate the time. Thank you for letting us present this, and just the work that you do. I mean, we do take the advocacy part of this very seriously, and we're working with med schools to increase the education for clinicians. And we're active members of a lot of these advocacy groups, including the ARC. So thank you.
Thank you. So before, I mean, we still have time. I want to make sure before we sign off, if there are any other questions or concerns before we get off. I know this was more of a short one, but I believe we covered all the relevant information.
Okay, let's
My-
see. What
My
else?
pleasure. My pleasure. Thank you so much.
All right. Thank you.
Take
Bye-bye.
care. Bye-bye.